So now I invite Professor Cayan to make a lecture on surgical treatment for thyroid.
Yes, based on the recommendation of Global Andrology Form Expert Panel. So we will be talking about surgical treatment of varicocele and outcomes of the surgery and complications, how the guidelines and Global Andrology Form experts recommend. In the first study, Dr. Agarwal and other GAF members compared changes in sperm parameters from the beginning of the treatment to the end of the treatment. This is the first study to compare changes from the beginning to the end of the study, actually. And what they found was all parameters significantly, including sperm concentration, sperm motility, sperm other factors, just significantly increased between the treatment and control group. The meta-analysis consisted of 16 studies, including more than 2,000 infertile men with varicocele, more than 1,000 had the treatment, and the others were followed as the control. And this is the first study to compare changes. And in the second meta-analysis, consisting of more than 300 papers, some were observational, some were randomized control trials, as you can see here. All conventional semen parameters significantly improved after varicocele repair in infertile patients with clinical varicocele. Varicocele repair also provided significant reduction in sperm DNA fragmentation, and also for the first time to show the decreases in seminal MDA levels in infertile men with clinical varicocele compared to control group, as you can see here. We also have just new data to show the impact of varicocele repair on assisted reproductive technique outcomes in infertile men. This is a systematic review and meta-analysis. This meta-analysis included 9 observational studies, and according to this meta-analysis, significant improvement in fertilization rate as just 10% increase. Varicocele repair provided at least 10% increase of fertilization rate with almost 2 times higher possibility to have chance clinical pregnancy and also live birth rate. So it means varicocele repair increased 2 times higher probability of having live birth and child. So the ideal treatment approach in infertile men with varicocele should provide significant improvement in sperm parameters, also with higher pregnancy rate. Of course, the operation should be performed easily with lower operation duration and also with the lower complication rate. So therefore, we should find any method to provide significant improvements with low complication rates. For this reason, we should aim ligation of external spermatic veins, at the same time also internal spermatic vein channels. We should preserve vas deferens and its associates with preservation of arteries and lymphatics. As I told you in the morning, so whatever we do, any kind of operation, we only have about 50% chance to get improvement with varicocele repair. The rest, we won't have any response to varicocele treatment for some reasons. Therefore, we should choose the best method which has provides the highest improvement in sperm parameters with the lowest complication rates. And just looking at the treatment model methods in the management of men with varicocele, surgery could be an option. Surgery could include laparoscopic and open surgery, and we can treat varicocele also radiologically. But just looking at the literature, including many methods here, as you can see here, the recurrence rate is ranging from 0 to almost 45%, and spontaneous pregnancy rates range from 30% to almost 45%. So the open surgical methods have the lower complication rates. Again, as I told you in the morning, the reasons could be unligated internal spermatic veins in 2/3 of the cases, and unligated external spermatic vein in 1/3 of the cases. Anatomic stations are just mentioned here. Localization of drainage could be different with every case. Here you can see another, I will show the video again. So GAF survey just asked GAF members, asked the members to perform which technique would be ideal to perform. So 2/3 of the members say microsurgical repair could be the best option to treat men, infertile men with varicocele. Here you can see a video at the same time. Subinguinal or inguinal incision could be made. Doesn't matter any kind of incision. If you go down, it's called as subinguinal incision, subinguinal approach. If you go a little bit up to achieve to the highest level at the spermatic cord, so it's called as inguinal or high inguinal method. Doesn't matter. The first aim should be, you should see the external spermatic vein. We always see external spermatic vein, but in 2/3 of the cases it could be very dilated. Here, you also pay some attention to preserve ilioinguinal nerve channel in order to decrease any nerve damage. And then, after ligation of external spermatic vein here, via subinguinal incision, then under microscope, you can see here, we were at the highest level of the inguinal incision. Under 15 to 20 times magnification, you can see here, so we will see, as macroscopically, it looks like just one vein here, dilated vein, to be ligated, but in fact, there should be at least 8 or 9 internal spermatic vein channels with 2 arteries and some lymphatic channels here. It's under 15 to 20 magnification. That's the main look at here. So we will see a lot of internal spermatic vein channels. So some could say just ligation of this large internal spermatic vein could be enough, but it's not true. We have to preserve all lymphatic channels and ligate all small internal spermatic veins. If we have any suspect to identify vein or artery, just we use Doppler probe under microscope. Another vein is to ligate the big vein channel. So there will be a few more internal vein channels to be ligated. We cannot see macroscopically. Some people use clips, we use just seat ligation. Here it could be cheap, cost cost effective. Here you can see very small internal spermatic vein channel. So we are guessing a few more internal spermatic vein channels and one artery. If we don't use microscope, we could miss some internal spermatic vein channels here. You can see here pulsation, but we can just drop a little bit vasodilator agent, but not necessary even. Here you can see the pulsation of artery easily under 15 magnification. To make sure again we can use hand color Doppler probe to hear, not color, maybe just to hear voices of the artery. Again, when we use microscope and to just, we can preserve all lymphatic and arterial vessels to increase the spontaneous pregnancy rate and also to lower the complication rates. So just looking at if there is any predictor for treatment of varicocele, if the patient has severe varicocele with normal testicular volume and gonadotropin levels, with sperm count of total motile sperm count of 5 million and lower infertility duration, this population could get more benefit from the surgery. In azoospermic men with varicocele, but the surgery could be also performed in the presence of normal spermatogenesis or maturation arrest at the spermatic level, and also having normal genetic test and close to normal testicular volume with almost no normal gonadotropin levels. In non-obstructive azoospermia, here you can see after varicocele repair, a third of men will have some sperm in their ejaculate, and the spontaneous pregnancy rate is too low in men treated for varicocele, but here you can see, I mentioned yesterday, in conclusion, varicocele repair significantly improve almost all conventional semen parameters in infertile men with varicocele. This is the first study, this was the first study by the GAF members has been reported to demonstrate changes in conventional sperm parameters after the surgery. A significant reduction in SFD and seminal MDA levels was also seen in infertile men with clinical varicocele after the surgery. Surgical methods provided higher improvement in sperm parameters and spontaneous pregnancy rates. So based on all surgical methods, microsurgical varicocele repair can provide the highest sperm improvement in sperm parameters and pregnancy rates. That's it. Comment, or we can also discuss the two sessions.
Okay.
Or
yes, we can let the discussion after the next lecture. Okay.
Okay.
So now I invite Dr. Fabrizio Castiglioni, who will